So the first presentation is going to be on PET MR imaging, and the title is The Best of Two Worlds, because I truly believe that that is what PET MR actually is. It is the best of two worlds. And this is an overview of what I would like to go over with you within the next 45 minutes, let's say 45 minutes instead of an hour. So starting out with the question, hybrid imaging, why should we even perform hybrid imaging? PET MRI in the application, why do we like PET MRI so much? PET MRI in the clinical setting in terms of primary and local staging as well as whole body staging. And then to me, one of the actually best application fields, which is the multi-parametric approach of PET MR imaging. And then to move beyond oncology and more go over to a step beyond oncology in terms of inflammation imaging. And then a bit more a critical question about the SUVs. So let's get started with the question, why do we like hybrid imaging so much? And this I would like to explain to you with this image of New York City. So this is a drawing of New York City, which is called When the Cow Comes to the Big Apple. As we all know, New York also has a resemblance of an apple. So my question would be, can anyone point the apple in this image? This is what a CT or MRI would be. So it's a lot of different shades of gray, a lot of anatomical information, very detailed. So it can get quite difficult to actually see the apple. And this is, or the metastasis, and this is where the strength of MRI, or PET, kicks in, because PET puts the focus on that one hypermetabolic metastasis that we are all looking for. The good thing is now we know there is a hypermetabolic metastasis. The bad thing is we don't know where it is, because we don't have any kind of correlation to anatomy. And this is where the strength of hybrid imaging kicks in, because it combines the beauty of high-resolution imaging, may it be CT or MRI. It adds up the metabolic information and then combines it to these beautiful fused images that give us all the answers that we are looking for. So PET MRI in the application, this is the scanner that we have. I believe there are two big vendors. Kapıyı çekebilir miyiz acaba? Çok teşekkür ederim, rahatsız ettim, çok sağ olun. There are two vendors out there that actually sell integrated scanner, çok teşekkürler, integrated scanner system, that's GE and Siemens. Ours is the MMR Biograph. We launched the scanner in March 2012, so it's been a good 4 years. It's based on an interdisciplinary cooperation among the radiology and the nuclear medicine department, and we've scanned so far more than 3,000 patients. And of course, our main indication field, and I think that's true for all over the world, is actually oncology. So when we look into the PET MR, integrated PET MR principle, it's very easy. It's the MR and the PET insert included in one machine. So if you cut through the bore, this is what you see. You have the magnetic shielding coil, the magnet coil, the gradient coil, and as well as all the PET detector systems. The problem why it took us so long to actually move from PET-CT to PET MRI is that conventional PET detectors are made of a combination of LSO scintillation crystals and photomultiplier tubes. The problem is, one, they're too big to fit into the PET MR system, and secondly, they also don't work in the magnetic field. So actually, Professor Pichler from the University in Tübingen had the great solution, or introduced the great solution, of using avalanche photodiodes that are way smaller, as you can see right here, and they also work in the magnetic field. So this was one of the biggest or most important steps to actually move from PET-CT to integrated PET MRI. The other issue is that, as we all know, for hybrid imaging, we need attenuation correction. For CT, it's easy because we can perform ROI analysis. We have all the densitometry, whereas for MRI, it was somewhat difficult. So different modules or modifications of MR-based attenuation correction had to be implied. These are the tracers that we use for PET MR imaging. It's the most often we, of course, apply 18F-FTG, which you can apply all over for oncologic imaging. And then we also use 68 gallium dotatok for neuroendocrine tumors, PSMA for prostate cancer, methionine for brain cancer, and then some iodine and fluoride as well. In terms of study protocols, when you go for hybrid PET-MR imaging, you have to make a decision. You can either go single injection, double examination, which means that you apply the tracer once and then perform a PET-CT as well as a PET-MRI. Or you can go directly for PET-MRI and only apply single injection and single examination and do an exclusive PET-MR scan. In terms of workflows, it's a very easy principle of simultaneous acquisition. So you start out with the localizers, which is what we know from MR imaging. And then you move from bed position to bed position, whichever bed position you would like to scan, and simultaneously acquire the attenuation correction. And then you start out with your PET and all the MR sequences that you as a radiologist or your cooperating radiologist would like to have. So there are different workflows or different protocols. You can perform a simple whole body protocol and a dedicated contrast enhanced protocol, for instance, for liver imaging. And I will show you our fast protocol that we use for whole body staging when we really just want to take 25 minutes and still gather high quality valid imaging data. So the question that may arise is, why PET-MRI? I love PET-CT. It's a great modality. I love all the answers that we get. So the question is, why do we need PET-MRI? And I would like to show this to you based on these three important issues. The first is that PET-MRI, or MRI, of course, provides a much better and excellent soft tissue contrast based on the MR component. So if we look into this patient here, this is a patient with these 3 hypermetabolic liver metastases based on a neuroendocrine tumor. As you can see, all 3 of them show some tracer uptake in PET-CT or PET-MRI. If we go one step back into only the arterial phase of CT, we can actually only detect 2 of these metastases based on the lower soft tissue contrast. And this is where the strength of MRI kicks in. Let me zoom in for you, because just based on the MRI, we can of course also detect those 3 hypermetabolic metastases, but actually due to the excellent soft tissue contrast, we can detect 10 further metastases. And this is where PET-MR becomes a game changer, because we're changing the therapy concept of this patient from local resection to just systemic palliative care. The other issue, of course, that is extremely important is the reduced radiation exposure when compared to full-dose PET-CT. This is extremely important for patients with non-fatal diseases, such as inflammatory issues, for children, as well as for patients with frequent follow-up for therapy monitoring. And I will show you some imaging examples on that as well. And the last, and to me probably most important application field, is actually simultaneous multiparametric imaging. Because now we can not only gather contrast-enhanced information, glucose metabolism, diffusion restriction, as well as all different parameters of perfusion. This is what true quantitative imaging is actually made of. And this is what we want to improve our diagnostics and potentially also improve the therapy. So let's look at some clinical imaging data. The good thing about integrated PET-MR imaging is that you can apply it everywhere in all application fields where you can perform MRI. So you can do breast imaging, you can do liver imaging, cardiac imaging, cervical cancer, or any other soft tissue cancer. As for liver imaging, we all know these tiny little liver lesions too small to characterize. So you can see them in CT. They're less than 5 millimeters, but they're too small to be picked up by PET. So what happens is that you write in the report, there's a liver lesion, it doesn't show any PET uptake, I'm not sure if it's just a cyst, a metastasis, or any other benign lesion. So we have to go either for follow-up or for an additional scan. And this is where PET-MR, based on the different MR sequences, gives you a one-stop solution and a one-stop answer. So this is the T2 weighted sequence. As we can see, it's just the liver cyst. There's no uptake. T2 shine through. So in this patient, it was actually just a bland liver cyst. Whereas the same lesion or comparable lesion in PET-CT, if we look into the MR component, we see rim enhancement in the post-contrast images. With time, we also see some slight uptake, and it is also restricted in its diffusivity. So comparable lesion PET-CT is actually a metastasis in PET-MRI, and you can now give a final answer to the patient. Lymphoma patients, to me, are one of the patient cohorts that will probably benefit the most from the application of PET MRI. These patients are usually very young. They're somewhere out 20 to 25 to 30 years old. And most probably, they will survive their first cancer because they respond to therapy very well. What happens in Germany is that we scan these patients with full-dose PET CTs every 3 months. So every 3 months, these patients undergo a full-dose PET CT scan with 20 millisieverts. So now we're actually risking to induce a second-line tumor and potentially kill this patient. Whereas if we look into the PET MR, as you can see right here, it's of extremely high quality. It's the same information we're gathering, just with much less ionizing radiation. So some of you, Professor Balger probably says, why don't we do low-dose PET CTs? Just as good for lymphoma, and it's true. So let me show you an image for a low-dose PET CT. This is a low-dose PET CT of a lymphoma patient. Low-dose PET CTs in our department are only read by the nuclear medicine department because there's no diagnostic CT to it. And the colleagues said, well, this is residual lymphoma, and this is just ectatic renal pelvis. So it's benign, it's nothing bad, it's physiological. This is the CT to it. Now we have a study that we're currently publishing where we compare PET CT to PET MR. So we asked the patient to also undergo a PET MR. This is the T2 sequence. And as you can see right here, this is an ectatic renal pelvis. This is solid tumor. So looking into the diffusion, it's also restricted in its diffusivity, so it's actually vital lymphoma manifestation. So we changed the diagnosis of this patient from the residual tumor, you can go home, you're fine, to unfortunately you still have vital tumor. So the question is, why would you like to settle for this if you can gather so much more information with the same tracer uptake and the same ionizing radiation? Soft tissue sarcomas, we have a very large cohort of patients with soft tissue sarcomas. To me, there is no need to perform PET CT anymore if we can have images like this based on PET MR. Beautiful information on infiltration or not. We don't need PET CT in these patients anymore. Prostate cancer is being really pushed in Europe, so it's getting into the guidelines. And if we look into, this is a full-dose PET CT of a patient with prostate cancer. This is the CT component. And I think we're all consent in saying, I see a prostate, I cannot tell you if there's cancer. CT doesn't provide us the information to detect cancer. We know that. So let's look into the PET. There's a focal tracer uptake. Good. So we can say the patient has prostate cancer. What about if the urologists ask, what about infiltration? What about surrounding tissue? You cannot answer that based on PET CT. So let's look into the PET MR, and all you need is a good, high-quality T2 weighted sequence. No endorectal coil, nothing special, just a T2 weighted sequence. We look into the post-contrast images if you want to. We can perform high resolution, and then we can fuse them and give the urologists all the information that they need about infiltration, about invasiveness or not. Even for lung cancer, studies have shown that for the analysis and evaluation of the primary tumor, as well as lymph node metastases, PET MRI can be just as good as PET CT. And there are specific indications where PET MRI is actually better. So this is a patient that was suspected for an infiltration of the cancer into the neuroforamen. So we performed a PET MR, T2 weighted sequence. This is the PET. We fuse it and we can tell them there's no infiltration whatsoever. Breast imaging is another one of my specialties, and we're also starting right now a study on breast imaging with local as well as whole body staging. And this actually takes me to the next point, which is whole body staging, because one-stop shop imaging to me is one of the best and most important application fields for PET MR imaging. Because now we can perform high quality local staging, breast cancer, prostate cancer, whatever we want to do, and then perform fast scans for the whole body and give the patient a one-stop shop imaging diagnosis. So we performed a study for the correlation of PET MRI for PET-CT for whole body staging. Every time you want to install a new imaging modality into clinical imaging, you have to compete with the gold standard. So the gold standard is PET-CT. So we could show that in terms of whole body staging, PET MRI is just as good as PET-CT for tumor detection. So you may say, well, that's not very attractive. That's not very convincing. I mean, it's just as good. It's not better. If we look into, and that's the point where we have to look into the ionizing radiation. For a full dose, whole body PET-CT scan, we have to apply almost 20 millisieverts of ionizing radiation. Whereas for the PET MR scan, we're only applying 1/3 of that, even less, 1/4. So you may say, well, looking at all of this metastatic spread, all of these are metastases. You may say, who cares? Who cares about ionizing radiation in a patient with this kind of diffuse metastatic spread? And you're right. But the importance is the information that we're learning. We're learning that PET MRI can be just as good as PET-CT, and we can use this now for lymphoma patients, for young patients, for therapy monitoring. That's what we're learning. The only problem that I had in our first studies was that our acquisition protocol was just too long. It took us 45 minutes to gather all of these sequences, whereas a full dose body scan for PET-CT only takes 18 minutes. And I said, if we want to implement PET MRI into clinical imaging, we have to be just as good with less ionizing radiation and just as fast as the gold standard. So we implemented a fast protocol. I like to call it a fast protocol. We reduced the applied sequences from 9 to 3 down to a haste, a diffusion-weighted sequence, as well as a post-contrast. And this is just because I love these 3 sequences. I love haste and I love vibe imaging. And we could show that the scan duration is actually, we were able to reduce the scan duration down to 26.5 minutes, which is now comparable to 18 minutes of a full dose body PET-CT scan. So now, and this is another study that we performed, we were able to show that the diagnostic ability of a fast protocol is just as good as PET-CT, just as good as the gold standard, with much, much less ionizing radiation and comparable acquisition time. The multiparametric approach to me is the most appealing and most interesting part of PET MRI. It's one thing to say PET MR, excuse me, is just as good as PET-CT for whole body staging. That's good. But that's not what we want. We want to gather more information, more diagnostic potential to really understand cancer better and potentially beat it better. So this is the point where quantitative imaging really makes it step up helps us to step up our game in terms of cancer defeat. So apart from all the information that we're now gathering in terms of contrast enhancement, glucose metabolism, diffusion restriction, as well as perfusion restriction or perfusion parameters, we can now use all of this information for all different kinds of tumors, such as this large cervical cancer here, to really understand the cancer better and then potentially also give up a better therapy. Just like in prostate imaging, where you can also add on spectroscopy and then use all of this information for personalized precision radiotherapy by integration of that multiparametric approach. So now we're going into local and really focal and personalized therapy over complete radiation on all the prostate, all over the prostate, or all over the breasts. And we've also learned that actually you can use these perfusion parameters to see and differentiate between responders, such as K-trans and IAUC. And they can also be used to assess, to utilize them as a predictive markers for early chemotherapeutic response. So now we're actually also differentiating between responders and non-responders, which is extremely important because, as we know, chemotherapy can be lethal and it has a large variety of side effects. We also perform multiparametric imaging for brain tumors, such as can be seen here in this large glioma, and this is the spectroscopy. And one of the studies that I'm most excited about, and that we have a cooperation with Siemens as well as the university in Cleveland, the Case Western University, is actually the so-called fingerprinting. I'm sure that it will be in the news within the next 1 or 2 years, where we can not only gather all the information that we already know, but we can also gather fast 30-second approach to relaxometry. So now we're gathering absolute quantification in terms of T1 and T2 values. So let's take a step beyond oncology. Let's move away from oncology. We've shown that you can also perform PET-MR imaging for activated facet arthrosis, and it can actually detect the activated facet arthropathy in patients suffering from chronic pain, which are now suitable for facet block therapy. So we can actually tell them it's this and that segment, and that's where you have to perform your therapy to actually help the patient. We can also use it for PET-MR imaging of the digestive system, such as in PET-MR enterography. So this is the study protocol that we perform. We perform a TrueFist, dynamic vibe set, a haste sequence with fat saturation, and then we also perform fast 2D flash sequences. And this helps us to detect or betterly detect potential focal active morbus Crohn or pancolitis, as can be seen here. And this is a study that we're currently evaluating for 50 patients, where we understand that the PET component really helps us to further differentiate between active inflammation versus chronic changes. You can also use it for vessel imaging, such as in large vessel giant cell arteritis, beautiful images, beautiful MR images with a whole body MR angiography. There's no need for CT, no need for anything else. You can just perform your PET-MR actually. And of course, you can also use it for cardiac imaging. Now, cardiac imaging is somewhat different in terms of the acquisition protocol, because you're only looking at the heart. So you're scanning the heart and the thorax for about an hour, 45 minutes to an hour. And that's how long your PET takes, and then you can gather all of the MR sequences that you want to gather. Now, the most important part about cardiac PET-MRI is actually patient preparation, because as we know, the heart has two partners for metabolism. It's glucose as well as fatty acids. And depending on the question that you want to answer, myocarditis versus ischemia, you have to prepare the patient. So you can either perform glucose loading. That's what you do if you want to see ischemic parts, because now the heart is completely showing tracer uptake, the vital parts. Or you can go for fatty acids and perform and give the patient a no-carb diet with heparin, and that's what you want to do if you want to go for myocarditis detection. So let's look at some imaging examples. This is a patient with an acute myocardial infarction. As you can see, he was loaded with carbs. Everything is enhancing, except for the part of the heart that's actually not vital anymore. This is a patient with a cardiac imaging ischemia where actually we did not really see any late enhancement yet, so we were even earlier than that. We did see some edema in the T2 weighted sequence, and as you can see, here's the corresponding reduced tracer uptake in the PET-MR part. And you can also go for myocarditis imaging. So this was a patient with a borderline myocarditis, so the MR didn't really help us. No late enhancement, no edema. This is a look into the PET component. There's your focal tracer uptake, and this is actually the fused image with the focal tracer uptake in this. So this was acute myocarditis that we would have missed based on just MR imaging. And you can even use the PET-MR for sarcoidosis and cardiac sarcoidosis. This is a pre-therapeutic scan. You can see all the lymph nodes here enhancing and enlarged. And this is the part of the cardiac infiltration or cardiac manifestation of sarcoidosis. And we performed follow-up scans for therapy. The therapy is very severe. It's like a chemotherapy. And 4 weeks later, we told them, oh, it's still very strong in uptake, so there's a lot of sarcoidosis still active there. And 4 weeks later, they titrated the therapy, and that's all you see. It's only residual. There's very minor parts of active sarcoidosis left right there. So what about the SUVs? This is a conversation that you always have to give or always have to discuss with when you are a hybrid imager. So we said that the attenuation correction is modified. It's not like in CT. It's based on a Dixon vibe sequence with an in-phase, a post-phase water and fat saturation, or fat, separation. And, but there are news to that. There are new studies that evaluate a novel model-based MR attenuation correction method, including the bone. I believe it will also be in the new E11 package by Siemens. And so we're really trying to include more bone information and be more comparable to CT-based attenuation correction. But the question or the discussion that I always show, this is the image, is for clinical hybrid imaging. I don't really care about the SUV being slightly different. So if I showed you these two cases, this is breast cancer, this is breast cancer. And if I then told you that the SUVs are about 10% lower in PET-MR over PET-CT, that's what we see, 10% less. Does that change your diagnosis from breast cancer? It doesn't change mine. Because as a clinical hybrid imager, I combine the information based on morphology with the PET component, and then I give my diagnosis. So my diagnosis is also a hybrid diagnosis. So I don't care if it's 7.1 or 7.7, this is still breast cancer. So to conclude, I believe we can say that hybrid imaging, or better, PET-MRI, is the best combination of both worlds in giving us all the information on oncology, mainly oncology, for local staging, for whole body staging, as well as the multi-parametric approach to really understand our defendant, the cancer, and to hopefully beat it better in the future. Thank you very much for your attention. So moving from PET-MR imaging to my second field of scientific research, which is ultra-high field imaging, I would like to start out with 7 Tesla, the more the better. So as you can see, it's a very critical question. And apart from the fact that I love 7 Tesla imaging, there are, of course, issues that I would like to criticize and discuss with you. So this is the overview of the next 20 to 25 minutes. We're starting out with some history. I'm sure most of you have seen these MR images. Then I'd like to show you some data on the Magnetome 7T, which is the scanner that we have. The question, why do we want to increase the magnetic field strength? Why are we so desirable for it? Why is it so desirable? And then moving on to ultra-high field whole body imaging, and then to the direct comparison of 1.5, 3, and 7 Tesla imaging as a comparison trial, and then the more critical end with the question, is the sky the limit? So let's start out with some history. I believe most of you have seen at least the image on the left. This is one of the first MR scanners, a prototype from actually my year of birth. So I guess I'm 36 years old. And this is just a 1.5 Tesla scanner from 2011 on the right-hand side. So I think just these two images actually underline the big change, the evolution that we've all been going through, or MR imaging has gone through within the last 30 years. So I believe it would be quite difficult to now ask a patient to go actually into one of these scanners, whereas this is a beautiful clinical scanner. And apart from the scanners themselves, this is also true for the imaging quality. So this is one of the first scans of the head ever performed from 1980. And this is just a normal T2 weighted scan from 2016, 1.5 Tesla. So looking at the direct comparison, I think also these images underline the evolution that MR imaging has gone through. And I'm sure that in 1980, there were some harsh discussions on, is this really what we want? Is this really what we need? And I think it took really brilliant minds, really set minds to say, no, we need to keep on pushing this because this is our future. And I think that's also what we should do with PET-MR as well as 7 Tesla. We need to look into the future and be visionable. So the Magnetome 7T in our department, it's not on the university landscape, it's on the coal mine because it was just too large and too heavy. So it stands in the Irvin L. Hahn Institute for Magnetic Resonance Imaging, which is 20 minutes from our university hospital. And as you can see, it's quite a big machine. So this is just the magnet, and this is just the cage of the magnet, actually, with 380 tons of metal in it. So that's an A380 as a machine. That's actually in this room right here. This is what it looks like from the outside. It's a bit old-fashioned. It's not as beautiful or modern as the new scanners, but I think the new scanner that's being sold by Siemens, the Magnetome 7T Terra, is also now a much more beautiful, more modern scanner. And the biggest difference actually between the scanners are the coils. This is what happens when you do 1.5 Tesla or 3 Tesla imaging. You call up your vendor, Siemens, GE, whatever your machine is from, and tell them, I want a head coil, I want a body coil, and a breast coil. And then you pay and you get the coils. This is what it looks like in 7 Tesla imaging. The only coil that right now is commercially available, so you can buy it, is the head coil. Everything else that I will show you, body, MSK imaging, is based on coils that our physicists built. So it's custom-built coils, which of course reduces the application fields of ultra-high field imaging, because if you don't have these coils, you're not performing body imaging. So why are we so eager to increase the magnetic field strength? I'm talking in a room full of radiologists, full of MR radiologists, you know the deal, so I will go quite quickly over this. The first issue is we love the increase in SNR, in signal-to-noise ratio, because we know that we can use the increased SNR into higher spatial resolution and or higher temporal resolution. And that's what we love. We love fast, high-quality images. The second issue is the improved susceptibility. So we can use this for an improved delineation of microvascularization as well as microhemorrhages. And the third one, and I think this is something more new with 7 Tesla, and I will show you the images, is the improved application of time-of-flight imaging as well as non-enhanced MR angiographic applications. So let's start with the improved spatial resolution. This is what happens when you perform 7 Tesla hippocampal imaging versus 1.5 Tesla imaging. This is the beauty that you can gather versus 1.5 Tesla imaging. Now, if you look into this image, this is microanatomy. This is what we've all actually learned in our books, and this is now what we can scan and show you. So all this microanatomy just in one image. If you take it outside of a living body into ex vivo scan and then compare it, you can see the MR looks just like the pathologic specimen. So it's beautiful one-to-one correlation of anatomy. What we're also hoping for, or what we're seeing and gathering, is new information based on that higher spatial resolution. So this is a patient with multiple sclerosis, and based on that improved delineation, we were actually able to understand that it's not just a T2 hyperintense lesion, but there are perilesional actually veins going around that lesion. That's something that we didn't know with less spatial resolution. So we're gathering more information on specific diseases. Now, susceptibility for the brain, at least, is one of the best things that you can gather and that you will benefit from at 7 Tesla, because you can use that improved susceptibility to detect potential hemosiderin, as in these cavernomas, and you can see the much more better and improved delineation of these cavernomas. You can actually detect a couple of more of them, and this is also true for patients with metastases of melanomas, because they also show hemosiderin. Now, of course, it doesn't matter if a patient has 1 or 50. If someone has this many cavernomas, it doesn't really matter. But it's a big difference if a patient has 1 metastasis or 20 metastases. And that's where 7 Tesla can really help us. Microvascularization is also something that we're improving with the improved susceptibility. So this is a patient with a large glioma, glioblastoma multiforme actually, and all of these dark lines in there, all of these hypointense lines, those are microvessels of the tumor, pulling in more microvascularization to enlarge faster. And this is something that we assessed, investigated for patients that are undergoing a second-line therapy, an Avastin therapy, which is a second-line therapy for neoangiogenetic purposes. So this is the 3 Tesla scan, post-contrast MPRH, post-contrast MPRH after therapy. And this is the corresponding susceptibility weighted image and the follow-up image. If you look into the MPRH scan, we kept it very comparable. No big deal. It enhances a bit more, but other than that, it doesn't really matter. But if you look into the susceptibility weighted scan for the follow-up image, you realize that here, it looks like the microvascularization has gone severely down, whereas if you look into the 7 Tesla image, you can actually still see that there's still a lot of microvascularization. So it's not really true that the tumor responded so well. And the third issue is the one that I was most excited as a resident when I performed ultra-high field imaging. It is the improved vessel delineation. So what we can gather now is this kind of quality of time of flight MR imaging. It's 0.2 times 0.2 times 0.4 cubic millimeters. And this is in a reasonable time. We're not scanning for 25 minutes. And this is the beauty that we can gather for pathologic disease imaging, such as these aneurysms. So now we're not only able to gather beautiful images with this TOF image, we're actually comparable and even better, I believe, than the gold standard, being the digital subtraction angiography. And this is probably one of the images that has gone all over the world. It's the imaging of the lenticrostriate arteries here. You can see this is the time of flight MRI. This is the anatomic correlation. Beautiful imaging, highly, highly detailed information. And this is something, hold on, I have to start the movie, that we discovered. I'm just trying to time here. That we discovered during our scans. We discovered that for non-enhanced imaging, this is the non-enhanced MPRH scan, there is a homogeneous hyperintense delineation of the arteries of the brain. So as you can see right here, we're starting out and they're homogeneously hyperintense. This is the post-contrast scan, and you see there's no big difference. So this was very, very exciting to us because we thought we can now lift the non-enhanced MR angiographic applications to another level for 7 Tesla imaging. So I said, well, if it's this good, let's see if contrast enhancement or the application of contrast actually helps us. And that's what we did. We performed a study where we investigated non-enhanced scans, MPRH, versus contrast-enhanced scans. And as you can see, for the circulus arteriosus villicii, there's no difference between post-contrast versus non-enhanced, which is good news for the patients because the less contrast agent we apply, the better for the patient. Only when we go more into the peripheral segments, such as M3 segments, this is where we saw some slight superiority of the post-contrast scans versus the non-enhanced scans. Now, as we said before, ultra-high field imaging, it started out with brain and also musculoskeletal, so that's easy. There's a commercial coil, you can apply it. So I said we need to go further. We need to expand the application fields and move on to body and MSK imaging. And that's what we did. So as you can see, it's 1.5 versus 7 Tesla imaging, and this is the diagnostic information that we're gathering in terms of degeneration of cartilage. It's much better appreciated at 70 versus 1.5 Tesla. Even for bone tissue, as you can see here, we can see the trabeculae much better than at 1.5 Tesla imaging with 70 imaging. And this is also true, of course, if we go into the small joints, highly difficult for us in 70. We can hardly, well, actually, it's very blurry and it's very hard to make any kind of diagnosis. 7 Tesla shows beautiful imaging, high quality anatomical details. Abdominal imaging was one of my major interests because I said I would love to apply 7 Tesla imaging to all over the world. So we started out with an 8-channel custom-built coil for that, and I tried to implement a standardized protocol. So these are the T2 weighted images of the kidneys. This is the in and a post phase image. And this is the non-enhanced 2D flash image. And this is, I believe our group was one of the only ones worldwide that actually went for dedicated abdominal imaging. And this image showed me that what we learned from the brain, the hyperintense delineation of the vessels, may actually also be true for abdominal imaging. So we looked into the non-enhanced T1 weighted scans. This is no contrast agent applied, and this is the delineation that we can gather from the aorta as well as the renal arteries. So again, I said, well, if it's already this beautiful, let's see what happens if we apply contrast. So we performed a non-enhanced versus contrast-enhanced scan, and we could show that, again, for the central parts, aorta, proximal renal arteries, no difference. Only when going into the peripheral parts, that's where we gathered some additional information. This is a dynamic scan. Of course, the application of contrast agent for dynamic imaging is extremely important for MR imaging. So we showed it's possible. You can perform beautiful imaging. And then we also had an incidental hemangioma in one of our healthy subjects or participants. And this is the non-enhanced versus the post-contrast scan. And as you can see, the only difference in terms of these two scans is actually the enhancement of the kidney, because the vessels look just like the same as they did in the non-enhanced scan. We also performed ultra-high-field imaging of the female pelvis, and then we decided, well, if we can perform it all over the body, we need to now step up our game and compare it to 1.5 as well as 3 Tesla imaging. So that's what we did. We took 10 healthy subjects and scanned them at our magnetome 1.5, the 3T, as well as the 7T. And we used comparable acquisition times and FOVs and tried to gather the best spatial resolution out of each of these magnetic field strengths. This is SWI imaging, or susceptibility weighted imaging of the brain. And I believe just looking at this versus this, there is no discussion needed that 70 clearly beats 1.5 and 3 Tesla for susceptibility weighted imaging of the brain. This is also true if we look into the cerebellum. Beautiful pontine vessels, not detectable at 1.5 T. Time of flight MR imaging also showed us that with 7 Tesla we're able to gather beautiful, extremely small peripheral segments that we were just not able to see at 1.5 Tesla, just based on the lower spatial resolution as well as the contrast. And again, for MP-RAGE imaging, we could show that based on 7 Tesla, we were able again to gather all the information on hyperintense vessel delineation versus 3T versus 1.5T. Now for abdominal imaging, the comparison is not as fair, because for brain imaging, we had a commercially available coil for 7 Tesla as well as for 1.5 Tesla. Whereas for abdominal imaging, we used our custom-built coil versus commercial. So these coils were, well, made by Siemens, and this is the coil that was made by us. And still, we could show that even with comparable voxel sizes, it's not really much improved, we were able to gather much crisper and sharper image quality based on 7 Tesla to detect this just incidental finding, which is an embleeded renal cyst on the left side of one of the participants. We also studied patients with cervical cancer. So this is the post-contrast vibe image. Again, very comparable, not really better at 70. But if you look into the post-contrast 2D flash image, you see this is the crisp image quality that we want to have versus the 2D flash based on 3 Tesla imaging, which is quite blurry and not so good in terms of tumor delineation. So is the sky the limit? That's the last and rather critical question. Now, of course, when we're talking about scientific research, when we're talking about ultra-high field, or when we're talking about life, there's always limitations. So one of the biggest challenges at 7 Tesla is actually the ZAR issue, because we know that with increasing SNR, we have an exponential increase of ZAR. And this can really significantly limit your performance in 7 Tesla, because you have to make sure that the patient is still safe. We also know, or we suffer from B1 inhomogeneity. So these were one of the first images where you can see that there's a significant signal drop everywhere we want to see. So we had to perform specific scanning and shimming to really push these kind of signal drops out of our region of interest. And finally, T2 weighted imaging is somewhat like a stepchild for 7 Tesla imaging. It's very difficult and it's stubborn. It's really hard to gather beautiful images. As you can see here, this is a T2 weighted TC scan. The liver is not even detectable. It's just blackened out. So this is quite difficult, so we had to work our way around it. And so we implemented a contrast enhanced MRCP instead, so that we still had our information on the biliary duct system. So what is there to say about 7 Tesla? The one thing that you always have to keep in mind, that its safety is really key. This is outside of our department. This machine is inside, and still you can see that the knives are standing. This is just due to the magnetic field because it's so strong. And so safety is one of the most important issues when you're performing ultra-high field imaging. And with that, I would like to thank you for your attention.